It started as part of my PhD in 2006 when phones were kind of like thicker than they were wide. It's kind of strange seeing, like, even that really brief SMS doesn't even fit on one screen. That's my phone there on the left. But we did this trial. It was a randomized controlled trial where we sent about every 3 weeks one text message to young people, the main focus being on chlamydia and increasing chlamydia testing and sexual health knowledge. So we had little, catchy notes like this. They were all short because then, like, SMS couldn't be more than 160 characters long. We tried to make them funny and catchy. And we found the results were quite positive. So I've just got a quote there from a participant about why he found it useful, saying that he didn't care about sexual health at the moment, but it was funny, so it sort of stuck in your head. And a lot of people kind of gave feedback like that because it was worth reading, not necessarily because of the sexual health content, they did read it and they might have showed it to their friends and thought about it later, and then maybe the sexual health stuff sort of snuck in as well. And what we found was that we had a significant increase in STI related knowledge, which was great, and among females we increased sexual health presentations at doctors and STI testing. It wasn't significant among males. We didn't have any impact on condom use though. So then moving forward to 2009, when phones were much different, like it's got a camera and it's got a colour screen, and we were able to do things like MMS, like picture messaging, and WAP, which at the time was like the height of new technology. I don't know if people actually remember this, but it was like you could get onto the internet by doing these like really complicated button pressing things, and it was really fiddly and terrible. But so what we did was, it was another randomized controlled trial, but this time it was kind of when we invented the whole concept, well, we probably didn't invent it, but we thought we did, of using 2 different interventions. So we kind of like doubled the bang for a buck, really. So the intervention group would get sexual health messages, and then the control group would get SunSmart messages. And then it would also work vice versa. So we were also doing a randomized controlled trial for SunSmart messaging, where the control group were getting sexual health messages. So how we recruited these people was we used a paid mobile advertising subscribing service. So we were able to essentially buy like ad space to reach these young people. And they got our messages, and we found that, again, we had some small changes in sexual health, and in the SunSmart group, the Sun group had no change in hat wearing frequency across the summer, which is actually a positive outcome because the sexual health group, by comparison, reduced their hat wearing frequency. So both of these were positive, at least to some extent. And now moving to, I guess, a more modern example of an SMS intervention. This is something we're doing at the moment for alcohol, and we've just finished the first trial actually. And we're able to use a lot of the capabilities of a smartphone to do a much more complicated and personalised intervention. So we've based it on the principles of a brief intervention. So that's, especially if you're an alcohol or drug clinician, you're probably very familiar with this. It's based on people give short reports of what they drink, and you give tailored feedback to them, which has been proven to reduce drinking. But instead of doing it as kind of like a thing in a clinic or maybe online, we have brought it into the actual drinking space. So while people are out on a night, like at a pub or drinking at home, they will receive SMS, and using their mobile smartphones, internet, they can do a really quick survey. It just takes like 30 seconds. It's just a couple of questions, like you probably can't see that properly, but it's what have you drunk in the last hour? And they get that throughout the night, and based on that we're able to provide a really highly personalised SMS. So rather than something quite vague like chlamydia is bad or alcohol causes cancer, don't drink so much, we're able to say something really specific, like for the example down there, we know that person has to work tomorrow, and we can send a specific message at say 1 a.m. saying you have to work in 5 hours, and then 2 a.m. you have to work in 4 hours, things like that. So the idea was that through personalising and tailoring messages, we're going to have more impact. And if you're wondering whether people would actually complete a survey every hour on their phone, what we found was that they actually would, because if you look around at a bar, half of the young people are on their phones anyway. Well, not just young people, all people. So it really wasn't considered to be an imposition. So we've got some preliminary findings of the study. Unfortunately, we didn't show an impact on alcohol consumption or on any of the other secondary outcomes. We think, it may be because the intervention doesn't work, but we're also quite underpowered, unfortunately, in our study because of the way we recruited. We just weren't able to get enough people to, we tried to convert them from being in a cohort study into being an intervention study, and they weren't that keen. I think they'd already been involved in research for about 3 years. So unfortunately we didn't get the numbers that we wanted, but we are going to be trying again. We did get some promising results in terms of acceptability. Just you can sort of see there that the majority of people agreed that the surveys were quick, easy, somewhat enjoyable, that the messages were useful, those sort of things. So now I'm going to talk about apps for health promotion. So I think that there really seems to be 3 different kinds of apps that are used for health promotion. So the first one, like I've got the HIV test finder there as an example, are kind of apps that are used as tools. They kind of utilise the functions of an app, whether that's the sort of computerisation stuff or location-based things. The second type is things that are attempting to gamify. So this example, I didn't really get how it worked, but it was some kind of condom intervention developed by a sexual health clinic in England. I think this specific picture in the middle is like you have to shoot the condoms or something with a laser. I don't really know how that promotes sexual health, but the idea is that, you make fun games and they have sexual health messaging in them. And then the third type are, like they say they're apps and they're on the App Store and you can download them as apps, but essentially they're really just like textbooks or encyclopedias, and they're just providing like information pages. But there are a lot of those sort of apps out there that are providing health information through that. And even though there's quite a lot of these apps out there, most of them haven't really been, well, very few actually have actually been evaluated properly, rigorously. I think the key problem with those sort of apps, particularly for sexual health, is that really no one uses them. Like, I'm a sexual health, researcher, very interested in the topic, but there's no way I would download one of those because, I don't really see the point. The kind of apps that people do use related to sex are things like this. So, like dating apps, or apps for meeting sexual partners, and more sort of fun sexual health or sex apps with things like sex positions was a really common theme that we found in a review. Like this one that has all 63 of the sexual positions. So it was great to learn 61 new positions. So we did a comparison looking at rates of how common, these kind of apps are downloaded by millions of people, whereas the ones on the previous slide are downloaded by 100 people who are probably, the researchers' friends, and I'm not saying they're all bad, but they're generally not quite as popular. So we were sort of thinking that, what if you could embed sexual health messages in these good apps rather than creating your own that no one ever uses? So we did a review looking at these kind of apps to see how many did have sexual health messages embedded in them. And what we found was that in 74 of the sort of entertainment apps like this one, only 3 included any sexual health information. Of the 44 dating apps targeting heterosexuals, only 1 had sexual health information. But for gay men, it's actually quite good. 7 out of 9 apps included some sexual health information. So, I was a bit surprised by the extent of the difference, but I think the apps targeting gay men tend to have a much more sort of responsible, community-focused message embedded in them, whereas the other apps are just kind of out there, not really providing anything positive although apparently Tinder now, since we did this study, which was about a year ago, has started introducing a few things like safe dating tips and things like that. So in terms of alcohol, we also conducted a review of alcohol-related apps. And one thing we were particularly interested in were these blood alcohol content calculating apps. So the way these work is you put in your gender, your weight, how many drinks you've had over what time period, and they will estimate your blood alcohol concentration. So this one's 0.02. But what we found was we got about, I think it was like 100 of these apps, and put the same data in all of them. We had some like real life scenarios where we knew how much that person had drank and how much their blood alcohol content actually was. And the range of results we got was just crazy. It was from 0% up to like more than 100% of your blood was alcohol. So it was quite concerning that most of these apps were just really inaccurate and not reliable. And possibly even more concerning were these ones that apparently could turn your phone into a breathalyzer. So if you blow on your phone, it'll tell you how much alcohol you've got in your breath. And we kind of thought it was a bit stupid, no one would believe that, but we also ran focus groups with young people where we got them to play around with some of these apps, and so many of them were like, like really hard blowing in, like it's not working. Yeah. But there are smartphone attachments now that really do work, and they're actually pretty cheap. Like I bought one, I think it was that brand even, on eBay for like $15, and I was playing around with it for a while and like getting my friends to blow into it, and it seemed roughly accurate. I don't know if anyone's actually looked at how they work compared to like a proper breathalyzer or like testing blood or something, but yeah, I guess these things, they have a lot of potential for research. So, you know, if one of the major issues with our area of research in health promotion is it relies very much on self-reported behaviour. So you never really know, even if you're asking people every hour what they're drinking, they might have forgotten in the last hour, they might not be completely accurate, they miss reports, but if you can collect real biological data, it's a huge advantage. So yeah, I guess that's something we'd like to do at some point. And I guess an even better model is like the whole Fitbit thing, which I am a victim of, a bit obsessed with it. But there's a lot of people using Fitbits where it essentially knows every time my heart beats, it knows every time I move, and this data is being sent somewhere, and if you could use that as, you know, part of your intervention, that would be so powerful. Yeah, I think there's a lot of advantages there, but one of the difficulties is, I think, so what Fitbit does, the amount of data and personal information it collects on you is just incredible, and to think, I guess as researchers, I can't imagine that we'd ever be allowed to do that. Like it just seems like it would never really ethically work. So yeah, I think there's a lot of interesting things to come in this field. And I was also wondering, like, in terms of sexual health, do you think there's an app that would, or a wearable device that would measure your sexual behaviour? And I kind of thought, no, it couldn't really exist. It seems a bit stupid, but there was actually a lot of them. So this one is like a little ring thing, and you wear it on your penis, and it measures like number of thrusts and speed and dilation, and there's a lot of these things, like for both men and women, and you know, records everything in your app, like, you know, how many calories you burned. You burnt a lot of calories in this position and you were going faster in this position, so you must like it, so try this position next time. So yeah, I think maybe there is a future for this in sexual health. It would be quite interesting. Okay, so now I'm going to move on to some of the problems and challenges I've encountered in this field of work over the last 10 or so years. I'm going to focus on these 4 different topics. So first of all, content development, which I guess isn't actually a problem, but I think the way that it's often overlooked is quite a problem. Like, you'd be quite surprised how little thought is often put into developing content for mHealth interventions. I think people think that, you know, it's only 160 characters, how much thought do you have to put into? You just write like, don't have sex or don't drink alcohol or something. And until quite recently, the usual mHealth intervention paper would not even tell you how they came up with the messages or even what the messages were. They'd just be like, we sent messages to young people every week about alcohol, and that's all you got. And there's been a lot of systematic reviews and studies that have come to the conclusion that SMS or mHealth interventions work, but I think that this is often perceived to mean that they just automatically work because they're on a mobile phone. But of course that's not true. Like if you text someone something like drink responsibly, it's probably not going to work. So it's actually the content itself that is what is going to be effective. And maybe the medium does, enhance it or create a new way of interacting with it, but it still has to be good content. And we have decades and decades of background theory and research in health promotion that shouldn't be ignored just because it's a new medium. So I'll just describe how we did the content development for our alcohol study recently. So it was quite an extensive, 3-phase project. First we had workshops and focus groups where people talked about things like their typical night out drinking, things that did and didn't encourage them to drink less or drink more. We went through quite a lot of existing health promotion campaigns about alcohol and got their sort of feedback on what they were. And then we also spent time with them, brainstorming their own content, like coming up with specific words they might use or different messages they might like to send. And then we got them to test it in a real life setting. So these messages were supposed to be coming to people while they were out drinking. So we got them to actually receive the messages while they were out drinking, because you might feel differently about a message at that stage. And then they came back in and did another personal interview to give feedback about the content and the process. So this is kind of the results, I guess, of what they told us. They said that it was fine to collect data every hour during a night out. We asked them if they prefer it via SMS or app, and they very clearly wanted SMS because they said they've got millions of apps on their phone, they tend to just completely ignore them. Whereas if they get an SMS, they will pay attention to it. We did, we offered, what if we did it every 3 hours, every 10 minutes, and kind of an hour was agreed upon. We changed the timing based on their feedback because we were thinking that they probably wouldn't be starting till 9 p.m, but they said, no, we often start drinking earlier, so make it start at 6 p.m. They proposed new questions to include in the surveys, and they spent a lot of time giving advice on the specific messages and content. So as an example, I don't think it was these specific health campaigns we showed them, but we showed them a whole bunch of campaigns like this and got their feedback on them. And I mean, those of you who work in alcohol probably aren't surprised, but young people tended to find these kind of negative and health-focused messages to be really irrelevant to them. A lot of people said that they were out of touch, they were buzzkills. And they just really didn't even care about that. If you tell me I'm going to get sick when I'm old, what do I care? I can't change that anyway. It's a short-term stuff I can do something about. And if you get alcohol poisoning, they just pump your stomach and you're fine the next day. And they were saying, especially when they're out drinking, they don't want to read negative stuff. They don't want to hear that they're going to get cancer because they're trying to have fun. They're at a party or whatever. And then I think another important part of the content process is identifying potential negative or unexpected adverse events. So quite a lot of people liked the kind of calorie-based messages, 5 pints equals 3 burgers. Particularly the girls were saying that it would just make them skip dinner, or it would just cause eating disorder related problems. And so then we avoided the calorie-based messages for that reason. I guess some examples of the kind of things we did come up with. And I should say that I've got 4 examples here, but we actually had 15,000 different messages because it was so highly individualized and tailored. A lot of them were just, if you spent $1, you get this message. If you spent $2, you get this message. But yeah, there was quite a lot of very individual messages, but they very much focused on really immediately relevant things and things that they actually cared about, like spending money, missing footy or work tomorrow, embarrassing your friends by being too drunk and messy. They were kind of the things they really cared about, not being sick. They didn't care if they had hangovers. They kind of expected that. And I guess feedback based on what they were actually doing that was relevant to them. A lot of immediate actionable things, like almost all the messages included something like get a glass of water. That's pretty common. And also we had quite a lot of positive messages too. So if they were spacing their drinks well, they reported they were having a really good time. We gave positive feedback. This is another study that I'm doing at the moment, which is a very, very different population, but also using mHealth. So we've got a group of sex workers in Mombasa in Kenya. We've actually just last week finished recruiting. We've got 880 of them in our study at the moment, which is really exciting. But we went through a very similar content development process with a group of sex workers before we started this trial. And again, we really wanted to make sure the content was relevant and that we were sending it in the right ways. And I think one of the reasons why I wanted to show you this is because the messages are quite different than the sort of messages that we'd send young people in Australia, as you might expect, but also just to show you some of the different kinds of messages that we sent. So in this study, we have 3 different kinds of messages. The first ones are push messages, which are scheduled to just go out, I think it's 3 times a week. They just get a regular message and it's sort of information about different sexual health and reproductive health issues. And as you can kind of see, they're a lot more serious and informative than the ones we would send to young people in Australia, because they, I guess, see it as a serious issue, so they don't think it should be kind of like, they were happy for it to be sort of friendly, but not a joke. And also I think another big difference is that they really wanted the information, whereas if you try to tell young people in Australia about drinking and using condoms, they don't want to hear it. So you have to like try and push it to them in a way they want it, like with funny jokes and stuff. The second kind of message we use are pull messages. So they're kind of on-demand messages. So people can text into the number for the study, and they just text a code like 00 or 12, and it opens like a menu. So you text 11 for information about implants, 13 for side effects of implants, all those kind of things. So they can get more information as they want it. And this is all just done through number codes on SMS. And finally, we have the role model stories, which come in a block, a few messages over a week, and they tell a story about a woman who's supposed to be kind of like them, who experienced difficulties, and in the end she ends up getting really good contraception and being happy and everything works out for her, which is kind of what we were hoping would happen with our participants. So yeah, this woman's talking about how she's new to town, her husband was violent, she's had scares with getting pregnant and she needs a new method to prevent pregnancy. And then like in the next story, one of her friends will tell her about IUDs or something, and then she'll go to the clinic and she'll get one, and yeah, it all works out well. I think one of the things that is really interesting that we were very surprised by is that we thought we were going to be translating these messages into Swahili, but as you can see, we've just got like a couple of random words in Swahili in some of these messages, and the rest is in English, and that is actually how we sent them to the sex workers. Even though pretty much none of them speak English, they told us that they're used to texting in English and they're used to seeing medical information in English, and they were actually just more comfortable with reading English on a mobile phone than Swahili. So I think, yeah, we're glad we found that out because it made it a lot easier for us as well. So the next challenge I want to talk about is equity. So there's the obvious issue that when you're using technology that costs money, richer people are going to have better access to it, and more educated people. These data are from the United States, but it's pretty much similar everywhere in the world. That more educated people have better access.
What year that's from? The breast tumours rapidly changed over the last few years.
Yeah, it probably has. I'm not sure actually. It's a few years old, definitely. And yeah, I think the levels will definitely smooth out. Even in Australia, where our smartphone ownership is much higher as a whole, it's going to be a lot less of an issue. But still, it is, particularly in remote communities, a lot of them, they don't have access. Maybe they can get a smartphone, but they won't have good mobile broadband, so other issues like that. And I think the other important thing to do with equity is, by nature, all these mHealth interventions are kind of individual behaviour change education interventions, and we do know that these generally tend to benefit the better off people. We know that education and behaviour change is less effective for people who, I guess, are worse off more broadly in terms of social determinants. So I guess by their nature, these interventions could potentially be exacerbating inequities in health. So it's kind of something to always keep in mind. So I'll talk now about technology problems. Essentially, my summary of this issue is that it always goes wrong. There's always something that goes wrong. This is from the recent alcohol trial. Even though we spent, I literally did this survey, the whole alcohol intervention every night for about 6 months. But still, when we went live, almost everybody had some kind of problem. The surveys didn't come, the messages didn't come, just everything. And even though I've used now probably a dozen different mobile companies, different types of interventions from really simple to quite complicated, every single time there's always technical issues. And I think, you just have to kind of accept that. And probably in practice, it's not really a big deal if someone misses out on a message, but in a research study, especially a randomized control trial, it can kind of mess things up. But I think if they're reporting honestly, I'm sure anyone who does an mHealth trial has experienced similar issues. So, one particularly bad example was from the study I talked about before, where we had the sexual health and Sun smart messages, and we actually wrote a whole paper sort of complaining about the tech company and all the things they did wrong, which was quite nice. You don't often get to actually publish your rants about people, but it was framed as, challenges in working in private and public partnerships. But yeah, it's an interesting read. So essentially, the issue was really, at a broad level, because it was through mobile subscribers, we couldn't do anything ourselves. They managed it all, and they didn't really get research and why we had to randomise things and why things had to happen at particular times. And so they kind of messed up the randomisation. They randomised groups, but then they didn't record who was in each group, so got a bit messed up. We also had a few problems where they told us our messages were offensive, but they never told us what was offensive about them. And we're assuming it's because they were about sex, even though they weren't really about sex. They were about STIs and condoms. But they would never tell us that. So they would often just censor messages and not send them, but they'd send the control group their messages, but then the intervention group wouldn't get a message until maybe a week later, once we'd resolved the offensiveness. And so that definitely created issues in terms of the equal between the two arms. Probably the worst thing was the reductions of message length. So a message is 160 characters. We spent a lot of time doing content development, focus testing, piloting with 160 character long messages. And then they told us, no, you have to include this thing at the end that says opt out, blah, blah, blah. So you've only got 144 characters. And then halfway through, I think this is when we had the offensive messages, they're like, oh, you have to add this extra thing now. So now you only have 107 characters. And then, of course, they reworded their message and we ended up with 90 characters in total. So basically went from this beautifully thought out thing that was like using theory and everything to being like, use a condom, it's bad. So yeah, it was quite difficult. And also again, because they owned all the data, they had to send it to us. Yeah, there was issues in that because it hadn't been collected in a way that I guess would be reasonable for research. Some other problems we've encountered in our more recent trials, which, yeah, I guess just things to think about that could happen. The alcohol trial, we were working with a developer in the States, and he just really struggled to understand that in Australia, daylight savings time was the opposite way to the States. And so he kept changing it in the wrong way and everything just kept happening at the wrong time. And yeah, and common problems we've encountered are things like the whole system's down, so the messages didn't get sent. In Kenya, there was like 2 days or something where the entire mobile phone system in Kenya was down. So, you know, we couldn't really do much about that. Phones being out of credit, out of battery happens a lot, particularly in developing countries like in Kenya. Like some women, if you don't have electricity at home, you know, you might go a week without being able to charge your phone, and you obviously don't get messages in those times. Yeah, we've just had difficulties with, I guess, you know, we might have very particular needs. You know, we want to send things at particular times, doing randomization, like randomization is actually quite a foreign concept to non-researchers, I think. So getting the tech companies to kind of understand things like that can be challenging. And another problem, this isn't really about the technology itself, but we can't receive and respond to participants' messages in a lot of cases. So if someone, say one of the sex workers in our trial texts us saying, help, I'm being attacked, we will see that, but generally we can't see it immediately. We don't see it for about 2 or 3 weeks. Which is kind of concerning, especially if she thinks that it's a helpline that is going to come and save her. Yeah, it's, and we do have like an auto reply that says, sorry, we can't receive your message, call this number, or go to the hospital, because there is no emergency number there, but go to the hospital if you need help. But yeah, it's definitely an issue. So the last problem I want to talk about is translation, so like research translation into health promotion practice. So I'm going to talk about a case study, which was the Sexual Health in Youth, or SHI, SMS program that was implemented by the Gippsland Department of Health, essentially, a few years ago. They contracted Headspace to actually deliver the intervention and us to evaluate it. And the idea was that because they'd seen my research with these simple kind of chlamydia-related messages, they knew chlamydia was a big problem. They wanted to try mHealth in Gippsland to see how it worked. And I guess they were hoping to achieve similar results that we had in our trial. So the aim was to recruit about 5,000 young people, mostly through schools and through a range of other ways as well, for slightly older young people. So of the 5,000 that we targeted for, we recruited 119. So less than 2% of our target range. And hence why I'm presenting this as a case study in translation rather than as the results of this fantastic study. So why did it fail so badly? According to health promotion translation textbooks, we essentially did everything right. It was based on a clear need. It was relevant to the target population. It was an evidence-based intervention that was proven to work. It involved researchers and practitioners in partnership, and the evaluation that I designed was very well designed. The issue was obviously recruitment. So in terms of schools, I think school recruitment often has issues like this, particularly in something like sexual health. Of all the schools in Gippsland, the private and Catholic schools didn't give permission. only 1 out of 10 of the schools, the public schools in the whole area, allowed a researcher to come in and present at an assembly, I think it was, about the study. And they handed out consent forms to all the hundreds of students at the school, and only 1 returned a consent form. So all that work to recruit thousands of people at school, we got 1 person. So I think these are kind of lessons that are probably relatable to any research at schools, but it is really important to engage with the schools really strongly, to get them on board, and if possible, if the ethics committees will let you, to have like passive consent or opt-out consent from the parents rather than requiring them to fill out a form and bring it in, because I mean, I think most of the students would have been happy to receive the messages, but they couldn't be bothered getting their parents to sign it and bring in the form. In terms of the other venues, I think the big problem was really limited resources. So our original sample we recruited from the Big Day Out Music Festival, and even though it was just 1 day of recruitment, we were able to recruit about 1,000 people. But we did put a lot of resources into that. We had about 25 staff. We spent quite a bit of money on like advertising and banners and like free giveaways and things. And this program, I guess, couldn't afford to replicate that. They only had 1 staff member. They didn't have 25 people to throw at it. And yeah, I think that was really quite a barrier. And in a lot of, because they tried to recruit from, just like on the street and in shopping centres, they found that young people were there with their parents, so they obviously weren't going to sign up for a sexual health program in front of their parents. And a lot of places, so they did try to go to things like the sort of smaller music festivals and events that were on in the area, which they might have done a much better job of recruiting, as we did at the Big Day Out Festival, but they were constantly turned away and being told that it's against the values of this event and the values of the community, which obviously no one has sex in Gippsland. So yeah, so I think the lessons that we learnt from this were you do need to do a lot of formative research about the recruitment. You need to know where different venues are. So at the Big Day Out, we knew it was going to work because we'd gone there the previous year and tried the same thing, just on a smaller scale with just a survey rather than recruiting to a study. So we had a really good idea of how to make it work. You need realistic goals and adequate resources to meet those goals. The ethics delays was actually quite a problem, because I think by having us involved as researchers, they kind of disadvantage themselves, even though it's always said, it's great when you work in partnership between research and practice. But if they hadn't involved us, they wouldn't have had to get ethics approval, and they would have been able to do things a lot more quickly, and they would have had more time for recruitment, but they had to waste 4 months getting ethics approval just so we could be involved. But I think the main thing that I took from this is that an intervention that is cheap and easy and convenient to deliver, because it's just through mobile phones, everyone's got them, they cost 15 cents to send a message, so you can just do it really easily. That doesn't mean that it's going to be cheap and easy and convenient to implement, because how do you get the people's numbers to begin with? That's kind of always been the really difficult question. And yeah, I guess there's a lot more to an mHealth intervention than just sending messages. So we've been doing a little bit of research recently, trying to understand better the barriers and issues that happen in terms of translation from research into practice in this field. So looking both at social media and mobile phone-based interventions, because we know that what happens in research doesn't necessarily make it into the real world, and vice versa, what happens in health practice, health promotion practice, isn't always based on research, or it isn't always evaluated. So we've done a qualitative study looking at some of the issues from both the perspectives of researchers who are kind of experts in the field and health promotion practitioners who might have had experience in trying to implement these things. So there's 18 interviews, I think 9 researchers and 9 health promotion experts. So the first issue we found was that there really are key priority differences, which is already something we knew, of course. But specific to these new technologies, the health promotion experts were kind of calling back to the equity issues that I was talking about before, saying they have always learnt they're supposed to be doing structural determinants type of work. They're not supposed to be doing individual behaviour change interventions. And they really didn't actually necessarily see the need for technology interventions. They often felt like they were doing them just because they could, or just because it was the new cool thing to do. Like this quote, every boss wants to do an app, but they don't know what it's for. We just know we're supposed to do them, and now it's pretty easy to do so. Like, I've had a lot of people approach me going, oh, we want to make an app for our service. How do we do it? My first question is like, what's the app going to do? And they're like, oh, it's just for the service. Like, it's just going to be one of those encyclopedia type of things. And yeah, I mean, my advice generally is just don't do it then. If it's not going to do anything, don't do it. But in terms of what researchers do, they often do things just because they can. And it's sometimes encouraged in a way that, you do something really novel that no one else has ever thought of, just to prove that it can work. And yeah, while sometimes that is obviously beneficial, it can also be like, what's the point of making an app that works when you know that no one's ever going to use it? And researchers said things like, we have to do things in a certain way to meet the expectations of the scientific community. They almost deliberately do things that aren't easily replicated, and that require quite a lot of resources and expertise. They need rigorous study design, large samples, and ultimately they are aiming to publish in journals rather than to have it taken up in the real world. In terms of resources, like I've always felt in research, we never have enough money, we have to make do with so little, but I think in community practice they're actually so much more worse off. I often forget. So as well as like limited funding generally, specifically they don't have access to peer-reviewed literature a lot of the time, so even though they know they're supposed to read the literature and get the evidence, they often can't. And they usually don't have any funding included for things like ethics applications, recruitment and evaluation. They're supposed to just put the intervention out there, and it's just supposed to end up there, and there's not much thought of how it actually happens. Researchers too are limited in funding and also particularly in time. This quote here, I could have said this. I say things like this a lot. I got contacted a lot to ask for advice. There's definitely interest out there. I just don't have the time. I'm working 6 days a week already, and I did that work more than 5 years ago. So if I had time, and I think it's definitely an issue that researchers have often moved on, and then someone's contacting them about something that they did a long time ago, or they don't, they're not in that field anymore. Then there's also the skills and expertise gap. So health promoters feel like they're already doing quite a lot of different things with limited training and expertise, and it's not realistic to expect that they're also communication experts. And one of the particular issues is that if they do read a paper, so like if they'd read my paper, the original randomized controlled trial, you would think that you can get a few $1,000s and then you'll just send messages to thousands of people. It's really easy. And now looking back, I'm like, oh, well, I can see why they thought that, because that's pretty much how we wrote it. The researchers often are leaving out quite a lot of the technical detail in publications. And researchers might not be thinking about replication, and they have, I guess, in terms of more resources and more time to spend on things, they usually do bring in experts, like outsourcing to IT people, and like people are always asking me like, oh, how do you make apps and how do you do this? And I'm like, I don't know, I don't actually do that myself. Like, there's an IT person who does that. I can download an app onto my phone, but that's about it. And I mean, I think even in terms of something like giving advice and evaluation, like sometimes people will come to me and be like, oh, can you evaluate this? But then, you know, they've got like $1,000 and you can't really do much for $1,000. Like I think in research, especially if you work for a university, like it costs more than $1,000 just to get someone to write the contract for you to do the research. So it is really difficult to have these partnerships when it's so unequal, I guess, and such different priorities. So just some recommendations that have come out of this for researchers. Try to include translation activities in your grant applications. You know, even to NHMRC, they say they're like pro-translation, but they really mean like commercialization of drugs and stuff, in my experience. But you know, you may as well ask for it and see if you get it. And also, I guess, try and advocate to funding bodies to take translation activities more seriously, so that the time you invest in kind of helping people do stuff that might not turn out in publications and grants, but is still worthwhile in terms of your research track record. Try to include practitioners and the target groups as much as you can. And a couple of things that I hadn't really thought about until this was publish in open access if you can, so that practitioners outside of research can get your papers. And also provide more detail in your publications. Things like how much everything cost is actually really important. And include everything you had to do, like all the little bits and pieces if you can. There are some, like the Consort eHealth statement includes things like including the cost of developing interventions and sending things. For practitioners, I guess the recommendations are really to try and evaluate and document things as much as possible, both successes and failures, because there really isn't enough documentation of failures from both perspectives, actually. Don't use technology just because you can and because it's new, and have realistic expectations based on funding. You know, there's, especially for mHealth and social media, it seems like, oh, it's free because it's free to send an email, but it's actually quite expensive to do things properly. Concluding, generally mHealth does show great promise for communication and health promotion, and there's a lot of new opportunities constantly emerging, you know, especially with things like wearables and new technologies like that. But I think it's important to remember that newer isn't always better. In terms of mHealth, I really do think that SMS is, at the moment at least, better than using an app, even though it's kind of the old thing. And I really think that a website is much more useful than pretty much any of these things, even though it's like the oldest new technology. And I guess remember that mHealth is only a medium. It doesn't replace health promotion expertise and content and practices. And yeah, acknowledgements, and I've just, some of the papers I was talking about there, you can, I'm happy for you to share the slides so you can see them. Thank you.